Hello and welcome to this research roundup. So by now, you know that from time to time on the Pediatric Network, we get hold of a really important paper and we kind of dissect it. And we bring out the important parts. We look at the methodology behind it. We look at, was it a good paper, a well-done paper? And does it have bearing on us as therapists, and in this case, particularly as manual therapists. So this paper is the comparison of common interventions for the treatment of infantile colic, a systematic review of reviews and guidelines. So in very basic terms, this is a paper published February 2020, a systematic review of systematic reviews. And basically what that means is this is a paper that took a lot of systematic reviews, which are already high-level research, and did a systematic review of those reviews. So basically, the outcome of this paper is quite important. So let's have an overview. Let's have a look at what they did in this paper. So, as we said, it's a comparison of common interventions for the treatment of infantile colic. It's a systematic review of reviews, and it includes guidelines. It includes 3 or 4 international guidelines as to what should be done with colicky infants. So the authors are Julie Elwood, Jerry Draper-Rody, and Dawn Carnes, and we are very lucky to have an interview with Dawn Carnes, which you will see at the end of this presentation. It was in the British Medical Journal, Open Source 2020, so we can all get hold of this paper, and it's going to be in the notes section of our open Facebook group. And here down at the bottom, this is the number if you want to go and search it yourself on PubMed. All right, let's have a look at the aim. What were they trying to achieve with this piece of research? So they wanted to review and compare the effectiveness of manual therapy to 3 of the most common interventions on colic symptoms in infants. And they looked at crying time and sleep and infant distress and adverse events. So crying time, sleep, infant distress, and adverse events, those were their outcome measures. Those were the things that they were looking for within these systematic reviews to see how well each of these different modalities, let's call them, performed. But the idea was to take manual therapy and plot it against 3 of the most commonly used interventions. And those commonly used interventions were probiotics, Simethicone, and proton pump inhibitors. So let's have a quick, just a rundown of those. Probiotics, so those are the good bugs that we want to be put into the system that are going to live inside the GIT and that are going to help the organism and the child and infant as we grow. We know that they have an effect on gas. We know that they have an effect on bringing down crying. And we also know that they have an effect on the immune system if you get a good microbiome going early on in life. Second of all, they looked at simethicone. So what is simethicone? So simethicone is a flocculant medication. What the heck does that mean? So a flocculant medication is basically a medication that breaks down the surface tension of the fluid inside that has moved into the stomach. So basically, breaks the surface tension of all the little bubbles that sit on top of the milk that has moved into baby's stomach. You break all of those little bubbles down, you get a big bubble. Theoretically, the idea is that now it's easier to move that big bubble out, and it's easier to burp it out, easier to fart it out, just easier to separate a lot of gas from the food. In some places it is called different things. I know you also get something called dimethicone, which I think, or I understand to be quite similar. I might be a little bit wrong on that, but all of my learning and all of my speaking with experts has told me that. And then proton pump inhibitors, they are drugs that should be used for acid. They are acid suppressant medications. They slow the proton pump in the gastric cells and the gastric parietal cells. And the idea is not as much acid being produced means that you would have less acidification of the esophagus, which you can have a look at in our GERD course because we go right into detail with that. So that's the aim of it. They were looking at manual therapy, and they were taking manual therapy and plotting it against probiotics, against simethicone use, and against PPIs, and seeing where does manual therapy sit inside that gambit of your normally used modalities. Okay, so methodology. What did they do to have a look through this paper? So They included systematic reviews, and as we've said, systematic reviews generally take your RCTs, your randomized control trials, and they plot them together, and then the systematic review comes out with what does the literature to date say. So they included these systematic reviews, and there were more than one researcher indicated in the review process, and that's really important because when you're doing a systematic review, you are having a look at what the data says, but you're interpreting it. And so you don't want it just to be interpreted by one person because that could mean that there's bias involved. So when they looked at the systematic reviews they looked at had to have more than one researcher indicated in the review process. And why? To reduce the chance of bias. Which means it's a good paper, right? Or it means it is moving towards, it has the makings of being a good paper. They didn't just look at systematic reviews, they also included clinical guidelines where clear methodological procedures for development were reported and included systematically designed evidence reviews and expert panel consensus. And when they looked at guidelines, they looked at national level guidelines only. So really what these researchers were trying to do is take the best of the best information, plot that together, and then have an outcome from that. So take all our systematic reviews, all the guidelines, and then, as they said as well, evidence reviews and expert panel consensus, and then come out with what does the evidence say for us right now. Okay, what else did they look at? The papers had to be somewhere in the last 10 or 20 years-ish, so 2009 to 2019, last 10 years. And then 32 references were finally included because obviously how research works is you go and you look for all sorts of papers with your title, and then whatever papers come in, you start to filter those down. You start to look into the abstract, you start to look into the full article, and you start to drill right down and find those papers that are really pertinent to the question that you're asking. So at the end of the day, they found 12 papers on probiotics. They found 1 for PPIs, or proton pump inhibitors. They found 4 for simethicone, and then 4 had a combination of these interventions that were assessed together. So let's look at the eligibility of a paper. How did a paper get into the systematic review of systematic reviews? So all infants had to be under 6 months old. They either used the Wessel's Rome 3 or Rome 4 classifications for colic. Now that's quite important because it's a wide net that they've thrown out. So the Wessel classification, that is the rule of threes, if you've heard of that. So it is crying for 3 hours a day for 3 days in a row for 3 weeks. Rome 3 kind of moved a little bit further and took the 3 weeks out and made it a week. And then Rome 4, which came out about 2 or 3 years ago, I think now, changed the game completely. So they kind of chucked out this 3 hours, 3 days idea and basically said, look, 3 hours is a little silly. It seems a little random. So what they talked about more was the fact that the child was crying inconsolably. And the child was under 5 months, and there was a whole lot of different things that the Rome 4 criteria took into account, which we will look at when we do our colic paper or our colic online teaching course. Okay, so you were not considered for part of this trial if you were diagnosed with gastroesophageal reflux disease. Why? Because then you didn't have colic, then you had reflux. And they separated those out because this was looking at what do these drugs and interventions do for colicky babies, not for diagnosed reflux children. And then, of course, because part of the diagnosis, or big part of the diagnosis of being a colic baby means you are otherwise healthy and you are thriving and there are no serious comorbidities. So that was a big part of the methodology of the paper of who would be eligible to be in there. Now, this is an important point because when it comes to your interventions, you kind of want to define your terms. And a lot of the time, and we'll see as this paper continues, this is something that manual therapy suffers from a lot, is that it's not defined a lot of the time in the research as to what is actually done with the patient for a certain outcome to happen. So the definition that they used in this paper was defined as predominantly meaning 75% or more, touch-based therapy, but it had to be administered by a trained and registered manual therapist, be that a chiropractor, an osteopath, osteopathic physician, physical therapist, or physiotherapist. So the outcome here is for manual therapy. If you're going to use these outcomes in practice and you're going to use the stats and you're going to use everything that comes from this paper, it is for manual therapy. It doesn't preclude one profession or include another profession. It is inclusive of all professions. All right, and then the outcomes. So what were the outcomes? We did talk about it. We alluded to it a little bit now. Okay, so the outcomes, they looked at crying times, they looked at sleep, they looked at parental distress, and then they looked at adverse events. Okay, so the discussion, what did they find inside this paper? So this is where it gets juicy. This is what we wanted to look for. So the 32 systematic reviews and 3 guidance documents were found, and these were the things that they used. Meta-analyzed the results, and the results showed that both probiotics in breastfed infants and manual therapy can reduce crying time. So important, what they found is probiotics, yes, but a lot more data for probiotics in the breastfed infant. And then manual therapy, both of those shown to decrease crying times. Daily reduction in crying was shown somewhere between, and it depended, but somewhere between 33 minutes and 76 minutes a day with manual therapy, and between 25 and 65 minutes with probiotics in breastfed infants. So this is quite a bit of time we're talking about that it's decreasing crying. The quality and strength of evidence was higher for probiotics than manual therapy. The evidence for probiotics centered around breastfed babies, as we said, rather than formula-fed infants, and a number of strains of different probiotics were used. So important there that it's not saying that there is no effect on bottle-fed or formula-fed infants. What it's saying is the evidence is highest when you were dealing with a breastfed infant on probiotics. Very important point there. And manual therapy evidence was based on low to moderate quality randomized controlled trials. We have to be honest about the data that we have. We have to own that. One of the important parts here is that there is no data that says that we are effective at decreasing crying time. The data is there. What is the data? It is low to moderate quality RCTs. Now, crying time was reported as the primary outcome in most studies. I find this when I look through colic studies, because generally we're talking about crying. So the biggest thing we're going to look at is how much crying has decreased. And it's used as a proxy indicator of colic resolution or improvement. Makes sense. Are they crying less? Yes. Is that better for colic? Yes. Makes sense. Okay, now, that is probiotics and manual therapy, and you kind of see they sit around each other. Now, PPIs and Simethicone also sit together, but in a whole different place. So the data for Simethicone and for proton pump inhibitors was unfavorable for colic children. 5 reviews concluding either no difference was seen when these were used, or worsening of symptoms was seen when Simethicone was used. And importantly, there is evidence, or was evidence seen in this review of serious adverse events when using PPIs. I see I've written PPE there. Of course, PPE is on everyone's brain at the moment. Forgive me, that is supposed to be PPI. Okay, what more did they find? So PPIs are designed to suppress acid, as we talked about, but they have consistently shown to be ineffective for irritability and fussing in infants with GERD. And we go into a lot more detail of this in our GERD course. But so PPIs are brilliant at stopping acid production. They are phenomenal at stopping acid production. We know that. The thing is that stopping acid production seems to be ineffective for irritable and fussing infants. It's an interesting outcome, and we really do cover that quite succinctly in our GERD course. And they are associated with increased risk of adverse events, things like infections, allergies, and hospital admissions. So, should we be using PPIs for colic? So, the evidence from Australia, quite interesting, shows that even though we know this, the proton pump inhibitors are overprescribed for infants with physiological reflux and symptoms of colic who may or do not have GERD. So let's break that down a little bit. PPIs are being overprescribed for children who have physiological, garden variety, normal. It's absolutely normal for them to have this kind of reflux, and that is reflux that moves any fluid that moves from the stomach into the esophagus or potentially out of the mouth, but it does not cause any adverse reactions into the child. The child is still thriving, they're gaining weight, they're doing all sorts, they're eating properly, gaining weight, everything's perfect. These children are being given too many PPIs. And children with symptoms of colic who may or do not even have GERD. And we know from that first sentence that PPIs, as well as they do with acid suppression, are ineffective for irritable and fussing children. Okay, so none of the guidance reviewed recommended using PPIs for treating colic. So that's good news. So the guidance, at least there, is sitting in the correct place. 3 of the 4 pieces of guidance recommended continuing breastfeeding and using physical contact, and not to recommend simethicone and manual therapy. That's quite interesting because the guidance is lumping simethicone and manual therapy, although we've seen here that there is a big disparity when it comes to the evidence around those 2 things, despite the difference in the current evidence between them. Okay, so just to backtrack on that, favorable, moderate to low quality for manual therapy versus unfavorable low quality for simethicone. So when you look at the data for manual therapy and simethicone are very far away from each other, yet the guidelines are not recommending both of them and they're lumping them together. Guidance and evidence do not reflect each other. And one of the things that the authors said about that is it's potentially a timing issue because these guidance, pieces of guidance come out once in a while, and obviously the data is coming out all the time. So the idea is that guidance will catch up, but at the moment the guidance is kind of old compared to where the data is at the moment. Okay, manual therapy, they're not always clear about what's done. So we kind of did speak about that a little. So you can't comment on the type or the quantity of manual therapy that may or may not have been effective, because when they looked through these papers, they didn't explain properly exactly what they were doing when they were giving these children manual therapy. And the finding of favorable but low to moderate quality evidence for manual therapy is different to other reviews. So a lot of the other reviews kind of just throw manual therapy out of the bath with the baby and the bath water and everything straight away. And they generally reject manual therapy as an option due to the poor quality data. But there are new studies, and that's just how research works. We change our standpoint depending on where the evidence leads us. And there are new studies that have raised the quality level of the data. And now there's a more favorable interpretation. And the more favorable interpretation may very well be due to the background of the authors. And we're going to speak to Dawn Carnes just now at the end of this. And she's an osteopath. Which means that she understands manual therapy, and she understands, as do the other authors, that manual therapy is multi-component. It's not a case of the child comes into the office, we do our manual therapy, and we hand them back. It's not just touch. There is so much more that's going on in a session of manual therapy, like reassurance, like guidance and advice and support that we give to parents along with the manual therapy. And it's that bundle, that basket that is offered during a manual therapy session that gives these outcomes. And we're giving all of these things to parents during a difficult time, and that also has a therapeutic role to play, which can affect the outcome of the child. So when we talk about manual therapy, it's important not to just go, well, it's just that. Because if you do research on it's just the manual therapy, you're not researching what we are doing in practice, because there's all these components that we're giving in practice, and all of them have to be put together to be able to say that is the outcome that's reached. Okay. So more high-quality studies are needed to increase the level of certainty, and this should cover the effect on the parents. So just a word here on adverse events that were, excuse me, frog in my throat there. Just a word on adverse events here. So no serious adverse events were reported in the randomized controlled trials for either manual therapy, simethicone, or probiotics. So we can kind of say that these are low-risk interventions, but you can't conclude that they are without any risk just because you didn't see it in these RCTs. And one of the systematic reviews did talk about or showed 88% less risk of adverse events in manual therapy groups than in the control groups. Quite interesting. And another showed 1 in 6 parents report non-serious adverse events. In one of the systematic reviews that they looked at, 4 serious adverse events were documented in case studies of manual therapy, including things like death, temporary paralysis, and rib fracture. But, and this is a very important but, these were poorly described and missed underlying pathology could not be ruled out. So there's a doubt over what the causality of these issues were. Overall risk, where reported, was low, and that is an important take-home. Risk of developing infections with probiotics were reported as extremely low, and proton pump inhibitors show adverse events, and those adverse events mainly are lower respiratory tract infections. All right, so let's look at the conclusions. What are the take-home messages? What is the big take-home message of the systematic review of systematic reviews and guidelines? So, from the paper, we found that the strongest evidence for treatment of infantile colic was probiotics, particularly Lactobacillus reuteri probiotics, and particularly in breastfed infants. That is where the highest or most effect was found. This was then followed by weaker but favorable evidence for manual therapy indicated by crying times. So both forms of treatment carried a low risk of serious adverse events. The guidance, however, does not reflect this at the moment, but the current guidelines will probably change over time in light of existing new and emerging evidence. So where does that put us? So we were, just to backtrack and just to put everything together in a nice little basket, we were looking at manual therapy versus probiotics, simethicone, and PPIs. At the end of the day, probiotics right up at the top, especially for breastfed infants. Underneath that, coming in with slightly less but still favorable evidence, was manual therapy for these children. Underneath that were simethicone and PPIs. Simethicone not showing a lot of change, and PPIs being responsible for some adverse events. So now, that's been my sort of take on the paper, but let's not just listen to me about this paper. We are now going to watch an interview that I had with one of the authors from this paper, and we're going to break it down even further. So here is myself speaking with Professor Dawn Carnes. Right. Hello and welcome to the Pediatric Network. My name is Mike Marinas. I'm your host and chiropractor here. And today I have the privilege and the honor of speaking with Professor Dawn Carnes. How are you doing?
Yeah, well, thank you.
Good. It's wonderful to have you on. And the reason you have you on is we want to talk about this, which is a piece of literature that, recent piece of literature that's come out, titled Comparison of Common Interventions for the Treatment of Infantile Colic, a Systematic Review of Review and Guidelines. So first of all, thank you and your fellow authors for putting this together. It's so needed in the manual therapies.
Yes, I think so, because we know that a lot of parents seek care, manual therapy care for their children with colic. And the problem is we don't know if the care is effective for the babies to help the parents make informed choices about the care that they're deciding their babies should receive. So hence the reason for the study.
Sure, and if it's difficult for the parents to understand, then it's definitely difficult for us as clinicians going in if we have research that's all over the place. So that's why I think it's so important to look at these, like you've done, these systematic reviews of systematic reviews, and then take the guidelines as well and go, what can we say to the parent that says, well, I'd like to come for manual therapy? What can we actually say to them regarding what the research is that's out there?
Yeah, it's all really messy. So what you're trying to do is make sense of a lot of studies using different methods, saying different things, measuring different outcomes. So the idea of a systematic review of this nature is to, try and make sense of it all, to try and come to some conclusions that can not only inform better practice by the clinicians, but like I said, also inform parents' choice.
Absolutely. So, and if the research is messy, the topic is definitely messy, because colic is one of those things that the etiology of it is just all over the shop. So I'm sure the job was quite massive to be able to pull that together, just to go, what definitions are people using? What are the outcomes that they're using? It must have been quite a thing to be able to put that together.
Yeah, well, the definition, I think, is relatively well agreed now under the Rome 4 criteria, and that was developed by a group of gastroenterologists, so it's sort of done on a global basis. So whereas it used to be Wessel's rule of 3, so three hours of crying more than 3 days a week for 3 weeks or more, that was the old definition. Now the newer definition, especially for research, is the 3 hours or more crying a day for more than 3 days a week. But actually now it says for more than a week. It's not only crying, it's distress, unsettled, but most importantly, difficult to console. So that's really important, for example, when you're doing randomized controlled trials and you're trying to recruit babies, because if you can pick up a baby and console the baby, then that probably doesn't come under the definition of colic, because the baby is easy to console. But as to what is making the baby cry and making them distressed and making them unsettled, again, there's lots of opposing ideas, not opposing ideas, there's lots of ideas about why these babies are so unsettled and distressed and crying a lot. And of course, it's the crying that upsets the parents most of all.
Sure, and this is where the efficacy of the treatment comes in, because if you're not too sure what's causing your problem, how do you fix it? So you know, but then that's where it comes in, where like a paper like yours has taken manual therapy, and then we've looked against probiotics, and we've looked against proton pump inhibitors, and then Simethicone. And Simethicone, for my guys in South Africa, they sell it as, the trade name is Telemint drops.
Okay.
I know Infocol, I think, is
Infocol and Colic, yes.
Yeah, that's it, yeah. And it's a flocculant medication, that's Simethicone. So it tries to break down all the little, like the surface tension between the bubbles, as far as I understand. Mm-hmm. Make it easy to come out.
Yeah.
So the idea being that you had, just to kind of skip through to the findings of the research, favorable in terms of probiotics and manual therapy, and unfavorable findings in terms of Simethicone and proton pump inhibitors.
Yeah. Yes, that's correct.
Cool, and I'd like to break down into that, because it's not just probiotics, it's probiotics for breastfed children. So there's a bit of a divergence there. It's not just saying so for everyone probiotics. So what do we then, as practitioners, say to someone?
Wait a minute, we don't just know if it's for breastfed. There's still a limited amount of research. There hasn't been enough research done on bottle-fed babies compared to breastfed babies. So it might be that certain probiotics are helpful with bottle-fed babies as well, but we just don't know that yet.
Okay. So to put myself in the picture properly, the evidence around using probiotics for breastfed babies is high-level evidence.
Yes, if there's more of it, and it's of higher quality. Yes.
Okay. So when it comes to a bottle-fed baby, the jury is out. It's not that it's not effective. It's just that the jury's out at the moment.
Yeah. I think we need more information to be able to make a good, considered decision about whether it's effective or not for bottle-fed babies.
But that's also really nice as a clinician to be able to have, because you'll get the question, and then you can say with all honesty where the research lies, and go, with bottle-fed, we don't know at the moment.
Yeah, we don't know as much as we do about the breastfed baby population. Yeah.
It is the strangest thing. The further I study and the more involved I get with everything, the more saying I don't know becomes really attractive, because it seems to be
Yeah,
That's what it
but
is.
that's the reality of working as a clinician. As a clinician, you work in so much uncertainty. You know, as soon as that patient walks into your room and you have to try and diagnose, then you're weighing up all sorts of information and the level of uncertainty surrounding not only the patient's history, your examination, your differential diagnosis, and then the treatments that you do. I mean, it's a massive arena in which to investigate, and it's all the time as you're making clinical judgments. And again, it's probably not just about one thing, it's the combination of everything that makes the difference.
Yeah, no, you're absolutely right. Because coming from that standpoint of going, I know exactly what's going on here. There's always a grey area, and you always have to have your mind open.
Yeah, it's not black and white. In the same way you say, is something effective? But is it effective for whom, in what circumstances, and how? So if I measure, for example, for the colic study, we measured crying. That was our most important outcome that we considered, but we measured lots of other outcomes. So we can say that there's enough information to make a judgment about crying time, reduction in crying time, but there might be other outcomes that there isn't enough information upon, there isn't enough information about that we can make decisions upon. So it's difficult. Effectiveness could be huge or it could be small, you know, on one dimension, or it could be on lots of dimensions. And most of the time in research, because it's so complicated to measure, you just get one or two outcomes that you will consider.
Yeah, but I really like the fact that we've got the crying time outcome as the major one that all the studies looked at, because just from my personal experience, that's what the moms walk in here talking about. That seems to be the big thing that's, yeah. And I mean, I have 2 children. It is the big thing. I'm not just saying it seems to be. It is the big thing. I want to move on then to the 2 that came out unfavorable. So proton pump inhibitors, which are more a gastroesophageal reflux disease medication. Yeah. What are they doing being used in colic babies?
Well, again, I think it's treatment. No, it's a diagnosis through treatment, and it's a diagnosis through treatment as a last resort. So it's more of a fear-led. From what I can get, there's a really nice Australian paper, I forget the author, but it's in the discussion. We talk about why clinicians are prescribing PPIs for colicky infants when it's actually not recommended. Even in most of the guidance, it's not recommended. So and it's more about wanting to do something for the infant and the parents, but actually in terms of safety, we're not sure if that's a good idea or not.
And as you say in your paper, it's increasing the amount of PPI that's being used in kids for fussiness and irritation, and a lot of the research is saying it just doesn't do much for fussiness and irritation.
And the difference between GORD, so gastroesophageal reflux disease, is that the babies normally are not thriving. So that would be the distinction between colic and GORD. Colicky babies are thriving. They're generally quite healthy. They're growing. They're okay. But babies with GORD are often losing weight. They're thin. You know, they're not well babies. So, you know, the difference between the 2 conditions is quite stark from a clinical perspective.
Okay, I get you. So the outcomes being on top of the pile of the evidence, the probiotics, with the amount of evidence that's out there and the quality of data that's talked about. Then sits manual therapy with low to moderate data, but still sitting in a favorable side, which is a little different to a lot of the research that's come out, and that is based on newer evidence that's coming out.
Well, the previous Cochrane review that was done by Dobson et al., and that was in 2012,
I think.
12, yeah. There's a couple more randomized controlled trials that have been conducted since. So we included slightly different trials to Dobson, and you can see in the paper that our results are a little bit different, but we made a judgment based on the newer trials that it wasn't low quality evidence, it was low to moderate quality of evidence. And of course, when you have a low to moderate quality of evidence, you have to bear in mind that with new research, you might change, the findings might change, and you might have to reconsider that evidence in the future. So there's a little bit of uncertainty around the findings because the quality of evidence is low to moderate. And the reason why it's low to moderate is because the trials perhaps don't have big enough sample sizes, so there is a possibility of error in the data.
And there's also that pesky thing in manual therapy research where no one ever describes what it is that they're doing.
Yeah, and it's very, very difficult, especially when you have professions like chiropractic, osteopathy, and the key selling point of this kind of therapy is the fact that it's bespoke, it's individualized to the patient. So actually recording what happens is quite difficult because there's a range of techniques that the therapist might use, but also when you then start digging deeper into it and you have to use palpatory findings, then again, you look at the research about reliability of palpation, it's not very good. So then you have to say, oh, now am I going to report that or not? Is my palpation concordant with another person's palpation? And then of course you've got the treatment itself. So if you're arguing you're increasing fluid flow, reducing tension within the soft tissue, increasing range of movement in any way, of course then you've got other measurement problems. This is from a research point of view rather than I'm in practice, doing my stuff. So then from that point of view, it also becomes quite hard to describe. So it's more about intent, what the practitioner has the intent of doing. So quite often now when for example, a randomized controlled trial that I'm doing, we're actually measuring this concept of intent, because we don't know if what the practitioner is saying they're doing is what they're doing. We don't know. So it's a very interesting whole area of domain, this whole concept of, what's the active component of any intervention, especially when you look at these kinds of interventions that we do as manual therapists. They're multi-component interventions. So it's not just the physical hands-on bit that makes a difference. It might be that relationship with the parent, the advice you give to the parent, even just saying your baby's okay, your baby's healthy, it's thriving, but I'm going to help your baby with its crying and I'm going to do this, this and this. Don't worry, I'll take over that bit, and it's nothing to do with your parenting. I mean, that might be a huge therapeutic effect in its own right. So we don't know. It's just very, very interesting. And this is a different type of research to investigate that than you would in a systematic review.
But that's wonderful, because as you say in this paper, it's not just the manual part, there's the multimodal therapy part. It's the advice, it's the being there, it's the support, it's that, being part of the journey. And like you say, taking some of the weight off and allowing them to kind of focus, giving them the correct tools. No, absolutely.
Yeah.
Absolutely,
yeah.
Absolutely. So I did just want to finish off by saying thank you so much for all the work that you're putting in. All of us that are out there in the clinics, well, I know myself, I'm riveted for the next paper, because I want to see where the evidence is going. And I think a lot of us in manual therapy are now moving towards, not that we were moving away from it, but focusing on becoming as evidence-based as we can to move into this new sort of era of healthcare. And if it's advice, to be able to give the best, most evidence-based advice that we can to parents. If it is a treatment, to be able to know that we're giving the most evidence-based treatment that we can. And that comes from papers like yours. So thank you very, very much for your time and all your effort. Really appreciate it.
My pleasure. I'm just glad you're reading it and using it. So I'm happy with that. Thank you very much. Cheers.
It's a pleasure. Cool. Thank you.